Okay, let's unpack this. Welcome to another deep dive. This is where we take just one source document
hmm
and really pull out the key insights for you. Today, it's a general postoperative protocol.
Right, from a vascular surgeon, Dr. Gregory Weir.
And this isn't just some textbook chapter, is it? This is like the actual playbook.
Exactly. These are the specific, actionable instructions given to nurses, to care providers who are looking after patients literally right after vascular surgery.
So our mission today, walk through this protocol, figure out the why behind the rules, and see what immediate post-op vascular care looks like based just on this document.
Yeah, what are the core elements according to Dr. Weir's instructions? It's a window into that specific world.
And we know where it comes from. It's got Dr. Weir's name, practice details, even contact info, so it's, official.
It really is. It's the formal guideline for care in that context.
Okay, so looking at it, it seems pretty well structured, broken down into sections covering the big stuff. Where does it kick off?
It starts with something absolutely crucial, especially after vascular surgery: blood pressure management.
Right, gonna keep that stable.
Definitely. The protocol gives really specific targets. The thinking behind it, you can infer, is all about protecting that new surgical work, the graft or whatever was done, and making sure blood's flowing properly.
Okay, so hit us with the specifics. What are the numbers?
Okay, there are two main ones. First, the mean arterial pressure, or MAP. Think of that as the sort of average pressure pushing blood around your body. That needs to stay between 70 and 100 millimeters of mercury, mmHg.
70 to 100 MAP.
Got it. And the other one? The other is the NIBP, non-invasive blood pressure. That's basically the reading you get from the arm cuff, the one we're all familiar with.
Mm-hmm.
That shouldn't go higher than 130 over 90.
Okay, so those are the safe zones. What happens if, say, the pressure creeps up too high, MAP over 100?
Right. If the MAP goes over 100, pressure's too high. The instruction is to titrate nitrosine.
Nitrosine. That's a drug to lower blood pressure.
Exactly. And titrate just means carefully adjusting the dose, tweaking it based on how the patient responds. They'd follow a separate protocol for exactly how to do that, but the instruction here is clear. Use nitrosine.
Makes sense. High pressure could really strain things. What about the other way? If the MAP drops below 70, pressure's too low.
This is where it gets interesting, and you see some clinical decision-making built right in. What they do depends on another measurement, the CVP, or Central Venous Pressure.
CVP, right, that tells you about fluid volume, doesn't it? Like how much fluid is returning to the heart.
Pretty much. It gives you a clue about the patient's hydration status. Are they maybe a bit dry, or are they holding on to enough fluid?
Okay, so how does the protocol use the CVP reading here?
Well, if the MAP is low, under 70, and the CVP is also low, let's say less than 10,
Okay.
that suggests the low pressure might be because there's just not enough volume, not enough fluid in the system.
So low pressure, low volume reading.
Exactly. The instruction then is give a 250 milliliter bolus, that's just a quick infusion of Bolawol or Ringer's lactate.
Standard 4E fluids, just a quick top-up.
Right. Give them a quick fluid boost to increase volume, hopefully bringing the pressure up.
Okay, that makes sense. But what if the MAP is low, but the CVP isn't low? Say it's over 10.
Good question. That's the nuance. If MAP is low, 70, but CVP is over 10, it suggests the problem might not be low volume.
Right, so just pouring in more fluid might not help, could even overload them.
Potentially, yes. So in that situation, the protocol says to consider giving inotropes.
Inotropes, what do they do?
They work on the heart muscle itself, helping it pump more strongly, more effectively.
Ah, so it's not about volume, it's about the pump.
Precisely. It boosts the heart's output, which can raise blood pressure. The protocol mentions Dobutrex titration as the preferred option here. But, and this is key.
Let me guess, call the doctor.
You got it. This step requires consultation with Dr. Weir first.
Interesting. So fluids based on CDP, that's sort of standard procedure, but messing with heart contractility needs the surgeon's direct input.
It highlights the different levels of intervention, doesn't it?
It really does, and it hammers home. Call Dr. Weir immediately if anything changes or if there's a bad reaction. That communication piece feels like a core part of the protocol itself.
Absolutely critical. Okay, so beyond blood pressure, there's a section on general blood management.
Yeah.
Pretty straightforward rule here. Keep the hematocrit above 30%.
Hematocrit, that's the red blood cell percentage. Right?
Okay.
Making sure there's enough oxygen carrying capacity.
Exactly. Keep it above 30%. And then there's a very practical, hands-on instruction you mentioned.
The blood pressure cuffs. Yeah, it says no cuffs on the lower limbs and definitely not on the limb that was operated on.
Makes total sense. You don't want to squeeze or potentially damage that fresh surgical work.
Simple but vital.
Totally. It also just notes that routine blood tests should be done per the hospital's usual process, mentioning by Lancet, which is likely the lab service they used.
Okay. Next section in the protocol, urine output. Another key vital sign, right?
Oh, absolutely. Watching urine output is huge. It tells you if the kidneys are getting enough blood flow, what we call kidney perfusion, and it's a great indicator of overall hydration.
You need decent pressure and volume for the kidneys to work.
That's it. And the protocol gives a really specific target rate.
What is it?
At least 1 milliliter per kilogram of body weight per hour.
Okay, so for like a 70-kilo person.
You need to see at least 70 milliliters of urine coming out every single hour. It's a clear benchmark. If it's less than that, something might be up.
So what if the output is low? What's the plan then?
Well, again, and this is interesting, it connects back to those other readings, CVP and MAP. It shows how interconnected this all is in the protocol's logic.
Okay.
You can give a fluid bolus, this time 500 milliliters of Bal-Sol or Ringer's lactate.
A bigger bolus this time.
Yeah, but only if two conditions are met. CVP has to be less than 10 mmHg, and the MAP has to be less than 100 mmHg.
Okay, so if urine output is poor, A and D, they look like they might need volume, low CVP, and their pressure isn't high, MAP 100, then try fluids.
You got it. That's the scenario where fluids might help get the kidneys going again.
But if those conditions aren't met, what if CVP is high or MAP is already high?
Right. If CVP is over 10 or if MAP is over 100, then just giving fluids isn't the recommended step. In that case, the instruction is contact Dr. Weir to discuss possibly using a diuretic.
A diuretic, like Lasix, something to help them pee out excess fluid.
Exactly. So it's a completely different strategy, used if the patient doesn't seem volume depleted. But again, it requires talking to the surgeon.
It's like there's a clear pathway for the straightforward low volume type issue, but anything else needs that higher level decision.
That's a good way to put it. The protocol maps out the decision trees. Then it gets into nursing care. And wow, this section really details the intense level of observation needed.
How intense are we talking?
Well, vital signs, blood pressure, heart rate, breathing, temperature, they need to be checked and written down every 15 minutes for the first hour post-op.
Every 15 minutes.
Then every 30 minutes for the next 6 hours. It's constant vigilance.
That's incredible. And it's not just the numbers, right?
No, not at all. Wound checks are just as frequent. Look at the wound every 30 minutes for any signs of bleeding or swelling.
Yeah.
And perfusion monitoring.
Checking the blood flow to the limb.
Exactly.
Yeah.
That's also every 30 minutes for the first 6 hours, then hourly after that.
So what exactly are they looking for when they check perfusion? What does the protocol say?
It lists specific things. Pulses, are they bounding, like really strong? Can you feel them? Are they palpable? Or are they absent?
Okay.
Temperature of the limb. Is it warm like the other limb, or is it getting cool? The color pink and healthy or pale, maybe dusky or bluish. Swelling. Obvious bleeding.
Lots to check.
And it specifically mentions checking for changes in Doppler flow and divide Doppler pressure.
The Doppler, that's the ultrasound thing, to actually hear the blood flow.
Yeah, you can listen to the pulse sound in the vessel or sometimes measure the pressure wave with it. It's a direct way to assess if blood is getting through properly. These are all hands-on checks right at the bedside every half hour initially.
Wow. Okay, what else in nursing care? Positioning.
Yep, specific instructions there too. The default is supine, flat on their back.
Standard enough.
But if the limbs start to get swollen, edematous, the instruction is kind of unique. Elevate the limbs, but not just with pillows. You put the whole bed in the Trendelenburg position.
Trendelenburg. That's head down, feet up, right?
Correct. Uses gravity to help drain the fluid back towards the body, reducing swelling in the legs.
Clever.
And then, interestingly, it says put the bed in anti-Trendelenburg. So head up, feet down during meal times.
Oh, that makes sense. To stop them from choking or aspirating food.
Exactly. Simple safety measure built in.
Yeah.
The protocol also notes Dr. Weir decides on dressing changes, unless there's an emergency bleed, which we'll get to, and mobility.
Right. What can they do? Can they sit up?
Good question. Walking and standing are okay, if and when they're actually mobilizing, getting up. But sitting in a chair, specifically not allowed.
No sitting. Why do you think that is? Less pressure on groin incisions, maybe.
Yeah.
Or blood clots.
Probably both. Avoids kinking things in the groin or behind the knee and helps venous return from the legs. Prevents blood from pooling.
Makes sense.
It also mentions standard pressure area care, just following the hospital's own protocol for that. And JVACs.
The drains.
Yeah, if they have them. They need to be emptied every 12 hours And you have to make sure the little bulb or container stays squeezed, maintaining the vacuum or gentle suction.
Okay, so many small but crucial details. It really paints a picture. What's the final major section?
The final bit covers a potential emergency: bleeding management. This is the what-if plan.
The serious what if.
First step for any wound bleeding, even minor, is tell the sister in charge. But if it looks like a proper hemorrhage, significant bleeding near the wound,
Then what?
immediate actions. Step 1, get all the bandages and dressings off around the bleeding area. You need to see what's happening.
Okay, expose the site. Then.
Reassure the patient, try to keep him calm, and ask them to lie as still as possible. Then you need to assess the bleeding.
How does it guide that assessment?
It specifically describes what suspected arterial bleeding looks like.
Mm-hmm.
Bright red blood, it's pulsatile-like, spurting with the heartbeat, and it's flowing fast.
Okay, bright red, pulsing, fast, alarm bells.
Big time. If you suspect that, the instruction is crystal clear. Contact Dr. Weir immediately. No delay.
Right. But even before you hear back, or if it's maybe not obviously arterial, is there something you do right away?
Yes. Absolutely critical step spelled out right here. Apply direct digital pressure.
Meaning?
Use your gloved hand, fingers or palm, and press directly onto the spot that's bleeding. Firm pressure.
And for how long? Just hold it until help comes.
The protocol is very specific. Hold that direct, firm pressure for 20 minutes.
20 minutes straight. Okay.
The time duration is clearly important. Then, after 20 minutes, you carefully release the pressure and watch the wound closely for 5 minutes. See if the bleeding starts up again.
Okay, 20 minutes pressure, 5 minutes observation. What if it does start bleeding again in those 5 minutes?
Then you go right back to step easy, which is applying the direct pressure again.
Back to square one, hold for another 20.
Yep, and crucially, it says you must phone Dr. Weir again if it restarts. Don't assume the first call was enough.
Persistent bleeding definitely needs the surgeon involved ASAP. Okay, what if the bleeding stops after the 20 minutes of pressure and stays stopped during the 5-minute observation?
Good outcome. Then the final step is to apply a clean wound dressing and use pressure bandages over it to help keep things secure.
Right. Secure it down.
And one last detail in this section, it provides a specific emergency phone number.
Having that direct emergency line right in the protocol underscores the seriousness. Wow. Okay, so looking back, this protocol we've just walked through, it's incredibly detailed.
It really is.
It covers blood pressure, fluid balance, with all these conditions based on CVP and MAP.
Those interconnected checks.
And then that super frequent monitoring of vitals, wounds, perfusion, specific positioning rules, the no-sitting rule, and then this very precise step-by-step plan for managing a hemorrhage, right down to the 20 minutes of pressure.
It's fascinating, isn't it, how specific it all is. The numbers aren't just suggestions, the 7100 MAP, the CVP under 10 trigger, the 1 millilocale urine output, that 20-minute pressure hold.
These are hard lines drawn from experience, you assume.
Absolutely. Designed to catch problems early and give the care team clear, actionable steps for complex situations, all based just on what's written in this single document.
And for you listening, this deep dive really gave you a direct view into the sort of engine room of immediate post-op vascular care.
Yeah, it wasn't just a general chat about it. We unpacked the actual instructions that guide that care, pulling out how it works operationally.
Shows the level of precision involved.
Definitely.
So, here's something to think about. Considering just how granular these instructions are, the exact numbers, the if-then logic based on multiple factors like CVP and MAP, the strict timings, the emergency flow chart, what does this tell you about the kind of thinking required in high-stakes care? It's clearly not just following a recipe, is it?
No, it's like a blend of strict rule following and constant dynamic assessment.
Right. It's do X if A and B, but consider Y if C or D, and always be ready to escalate and call for backup.
Yeah.
It's a fascinating insight into that world.